I'm Alyssa Fairchild. I'm a radiation oncologist. I work at the Cross Cancer Institute.
My name is Bronwen. I am a radiation therapist and I work in palliative radiation oncology.
I've been working in the palliative radiation oncology clinic since 2007.
Screening for distress is a tool that I use for every patient, regardless of the situation. If a patient is an outpatient that's being referred to us, then we have hyperlinked the screening for distress form into our referral form. So referring physicians can print it off, have the patient fill it out, and they can fax it in with their referral form, which is really nice. So it gives us a little bit of information about the patient before they show up.
If a patient needs palliative radiation, you can be sure that that's not all they need. And the screening for distress just provides a tool where patients can actually quantify what their needs are, which is different than looking at somebody from the outside and sort of deciding based on what they say or based on how they look. So it's a very important way for patients to tell us what they need.
The screening for distress is done at the time of consults. It comes with their information package when they check in. They fill it out, and then I use it to determine, what is important to them.
You never know what patients need or what struggles they're having or what burden they carry until you ask. And it may be that you're not the most appropriate or the best person to help address, but at least you can work with them to develop a plan.
It helps patients communicate with me what's important to them so that I'm not asking a bunch of questions that aren't relevant. It makes it much quicker for me to hone in on the things that are really important and then allow the patient to elaborate in their own words.
The screening for distress has helped me learn that a lot of times I'm not the most important person to a patient's care plan at that particular moment. One example is a gentleman whom I saw recently with an anal canal cancer, and he had so much difficulty sitting that he really couldn't do it anymore. And it wasn't until he filled out the screening for distress and sort of specifically pointed out that that was impacting basically all parts of his daily life that it would have dawned on us to ensure that he was seen by an occupational therapist for a custom cutout cushion for sitting comfort. And he told me later that that was the best thing that anyone ever did for him, over and above the radiation or the analgesics that I provided.
Maybe there's something that's more important than the reason why we've brought them here today, and that's what we actually need to be dealing with. It did take me a while to get good with the form and just find out what works for me and what helps me to eliminate things for patients. That's where the art of having a conversation with somebody from a medical standpoint comes in, because you have to know how to cone it down a little and find what's important, but then also pick out the pieces of information that maybe you didn't think was relevant initially, but probably is in some way.
We've seen how powerful it is for patients to tell us their stories, and we are only able to help them if we know what the unmet needs are.
It moves away from the paradigm of the paternalistic healthcare provider telling you what the problem is and what we're going to do about it, and towards more of a patient-centered approach.
We've seen the impact that we can have if we work together as a team based on the results of the screening for distress.
You just have to find a way to make it work in your practice.